And, you know, there's a saying where it says, when you hear hoofbeat, think horses, not zebras. And the idea is that most people will think of the things I said. They'll think about asthma. They'll think about COPD. They'll think about out of shape. They'll think about inactivity. And if you have any of those things, then most people and a lot of physicians are perfectly fine going along with that idea, right? Except that when you have ILD, the clock is ticking in a way that's different than the obstructive diseases like COPD and emphysema. Okay, it's different. So the idea is emphysema, if you get a diagnosis a year, or 2 years, or 3 years late, not to say it's a great thing, but it's not the same as getting a diagnosis 3 years late in a disease that is notorious for having a 3 to 5 year lifespan, right? And just to address that before we go on, because that's something that rocks people's world when they hear that. So you get diagnosed with an ILD, particularly IPF, and they say 3 to 5 years. So everybody goes on the internet and they go into an immediate panic, right? And rightfully so. Okay, rightfully so, I get it. But the idea is that, like I said, things are changing a lot. And so, you know, another thing that Dr. Kaner said that's so interesting is that why didn't people test for it before? Because there was no treatment for IPF. So people figured, well, why should I test for it if there's nothing we can do about it anyway, right? Which is kind of a sad, and I know that's not how he feels, but that's a sad way of thinking, right? Because, you know, you hear someone growling in your closet, I'd like to know if it's a dog or a bear. I may not be able to do anything about it, but I want to at least know what I'm dealing with. And so for any type of chronic disease, it's really important that you educate yourself. And my point in this, in giving you number one of the question, is that getting the right diagnosis is the single most important thing, okay? And I put with that, getting the right diagnosis early, right? The reason for that is that unlike the obstructive diseases, which are all pretty similar, some of the treatments for some ILDs are actually detrimental to other ILDs. So not even do they not help or do anything, but they can actually harm. So one example of that is, you know, let's say like an NSIP, non-specific interstitial pneumonia, the treatment is high-dose steroids, okay? But steroids in the IPF patient have actually been found in studies to be detrimental. So if you don't know and you want to just, you know, kind of use an all or nothing or kind of a standard approach to ILD, I think the thing that's most important to understand is that there's no standard approach. And you really have to get the right diagnosis. And that may mean that you have to travel in order to do that, okay? If you have nobody in your town who's a specialist in ILD, or if you have nobody in your town who's even a pulmonologist, as I've heard from some people, you have to travel at all costs, right? And so like if you were sailing in a boat, and let's say your boat sprung a leak, you would do every single thing in your power, regardless of cost, regardless of timing, regardless of anything else. You would treat that as a matter of urgent emergency to either fix that leak or get rescued, right? Yet when it comes to diagnosing a potentially life-threatening disease, we say, well, you know, I don't want to drive 3 hours to the nearest center or something like that. And that makes no sense. So an analogy that I thought of this morning is, imagine you're on a ship. Your ship is equivalent to your diagnosis is a cannonball comes through your ship, right? And all of a sudden your ship now has a hole blown over it and it rocks your world, right? If you're not expecting that, all of a sudden your mind is blown because you're hearing all these things about interstitial lung disease, IPF, and you're hearing a 3 to 5 year lifespan, et cetera, et cetera, et cetera. And you're often hearing them from people who don't have a great handle on what these things are. So first and foremost, get the right diagnosis, okay? Just as a show of hands, how many people have IPF? And I can't see everybody at the same time. Okay, so of the people who said they have IPF, show of hands, how many of you know the cause of your IPF? You do? Okay, Michael Wecker, you don't, right? Okay, good. That was a trick question, okay? It's a trick question because the idea is, I hear people all the time say, I think my IPF was caused by living near a chicken coop or something like that. And the idea is that, hey, Scott, the idea is that people are popping in and out of my screen at different times. This is funny. But the idea is that the first delineation in terms of differential diagnosis is, does your disease have a known cause or an unknown cause? Okay, is the cause known or is it unknown? And there are certain diseases, certain ILDs, in which the cause is very well known. So things like occupational lung diseases, where basically you're exposed to toxic materials, and usually these things are inorganic. So inorganic dust, things like coal miners, okay? So coal workers, pneumoconiosis, or asbestos, right? People who are working with asbestos. So that's a known disease, and you can trace the etiology of that disease and the cause of that disease, and then you have some decisions to make, right? Something like a pneumonia is known to cause ILD, and then of course you need to treat the infection if it's still present from bacteria or viruses or fungus. Autoimmune diseases, things like RA, things like lupus, scleroderma, Sjogren's, things like dermatomyositis, polymyositis, things like anti-synthetase syndrome, okay? And you hear what I'm saying. These things sound complex. Like if you hear emphysema, most people know that. If you hear some of these things, they give you absolutely no clue as to what's going on, okay? Other things like drugs, okay, can cause pulmonary toxicity. Things like bleomycin, which is like a drug that's used for chemotherapy, or there's a cardiac drug called amiodarone, which is an antiarrhythmic. It's used for other cardiac things, also known to cause cardiac toxicity. But if you had no lung problem and you went on, let's say, amiodarone for atrial fibrillation, and then all of a sudden a year later you have pulmonary fibrosis, then we can point to that and say, hey, you know what? There's a good chance that it was the amiodarone. And while we're on the topic, let's just say this. Not all pulmonary fibrosis is not a diagnosis, okay? I'm going to try to say the whole rest of this in a rhyme, but pulmonary fibrosis is not a diagnosis. IPF is a diagnosis. Pulmonary fibrosis means scarring of the lungs. And there are many different conditions that can cause pulmonary fibrosis, but it doesn't necessarily mean that you have IPF. And that's where this differential diagnosis is, okay? Then there's another class of diseases where it's basically exposure to organic toxins. So things like mold, fungus, birds. I had a lady a few years back who was a physician. She was a researcher. She worked in a room about this size. The thing is that right outside her window, living on her air conditioner, were about 200 pigeons, okay? So if you can imagine, for all this time, this woman is sitting and working and researching and just doing her thing, and these pigeons are just flaking off, feces and feathers and all this stuff, and it's going right near her air conditioner. And there's only so much that a air conditioner filter is going to do. And this led to, one of the things that we say, like hypersensitivity pneumonitis. And these are all the known causes that I've just mentioned already. Okay, so that's the first delineation. So first delineation is column A, column B. Is it known? Is it unknown? So if it's known, we rule out IPF. Now, if it's unknown, we have IPF. And then we have something called NSIP, which is nonspecific interstitial pneumonia. And as Dr. Kainer also says, that's a misnomer also, because A, there are specific criteria for it, okay, and it's not an infection. And very often, the only key to diagnosing the differences between these different diseases is really to go through, number one, a chest x-ray, but that's not going to give you a diagnosis. Pulmonary function test is not going to give you a diagnosis. A CAT scan, and in particular, a high-resolution CAT scan in which the slices are very, 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 very thin, because many of these things are microscopic, okay? And then sometimes, even in the case of where a CAT scan points to something, it's not enough, and you have to get an open lung biopsy, or, a VATS, a video-assisted thoracoscopic, surgery, in order to really determine the true cause of the disease. And that sounds like a lot, okay? But remember what I told you, You've just had a cannonball come through your life and through your ship, and you're taking on water fast, okay? So first order of business, we have to stabilize the ship. We have to stop ourselves from taking on more water. And that means that if you know the source of the exposure, you have to eliminate that immediately, okay? If it's a job, if it's a pet, and I hear people say, you know what, I've had this parrot for 20 years, I can't get rid of him. I sympathize. I have pets. I love pets. I love animals. And I probably wouldn't do it either. But you have to, know the information so that you can make the best choices for yourself. Okay, everything's a choice. And people are entitled to make decisions for themselves. And I trust people to know what is best for themselves. And you know what? For me, I can't think of anything that would make me give up my dogs. I just can't. But you have to really decide, this is the potential ramifications and what are you going to do about it? So that's number one, okay? And I'm long-winded, so, this is going to go for a while, but I want to give you all the information in a way that's clear and in a way that maybe you haven't heard it before. I want everyone to come away from this saying, oh yeah, I didn't think of that. So getting the right diagnosis as early as possible. Any questions so far? Any questions so far?
If you have a question, you can turn off your
Mary
speaker.
Jo has a question.
Yeah, I have one for you. I'm fairly new to IPF. I've had the diagnosis, but I'm getting a second opinion from Dr. Maggetto at Baylor Lung Disease, and just for the reason you gave, I'm not sure that the initial pulmonologist diagnosis is right. And I'm taking OFEV, and I understand it only helps IPF. So
Only
if I have something
IPF,
else, why am I taking the drug?
Agree 5,000,000%. That's the question right there, right? So IPF treats one thing, and you have to think of these things like, those toys your kids have, there's like that blue and red ball, right? And it pulls apart, and inside are all the shapes. And there's like a star and a square and a circle and a moon. These are specific. So you're not going to get the moon in the star. You're not going to get the square in the circle, right? And it's the same thing. OFEV, Esbriet only treat IPF. And if you have something like hypersensitivity pneumonitis, then guess what? You're taking the wrong medicine. So you're taking the medicine that is not without side effects, by the way, okay? Is not without side effects. There are some serious gastrointestinal side effects that I know people who the side effects are not worse than the disease, but they're, sorry, Alexa is talking to me for some reason.
I don't see Dad in your contacts. What is your father's first and last
Hold
name?
on, I'm gonna shut this.
No, I'm convinced that both Alexa and Siri hate you and me.
Yeah, it's true. Well, she just said something that was completely false. She said, what is your father's name? Your father is not in your contacts. So if my dad is listening right now, he's going to be insulted, okay? But the idea is that I agree with the second opinion. Now your name is R.P. Morgan, right? Shake your head. Put your hands on your head, R.P. Morgan.
It's Dick Morgan, yes.
Like this? Okay, gotcha, okay. Have you had a biopsy, an open lung biopsy?
No.
Have you had a high resolution CT scan?
Yes, but I don't know the results yet. Dr. Maggetto did a lot of blood testing and the high resolution CAT scan, and she sent some of the information to Mayo, and I should hear probably in the next 3 to 4 weeks what her analysis is. She was somewhat critical because the initial pulmonologist that I went to made the diagnosis based on a chest x-ray and a CAT scan, period.
Right there. Sorry to curse, but that is some BS. That cannot be made. You cannot make an IPF diagnosis based on that. It's impossible. You know why? Because you haven't ruled out everything else. You haven't looked at the known causes. So if you don't know, it's like saying, I don't know what's under this blanket, but I didn't look under this blanket. And you must rule out the known causes before you decide that it's an unknown cause. And once you can't find anything, and what you said is high resolution CT scan, so it starts with a history, right? It starts with a very, very careful, attentive history. And there's a research study that I read a few years ago that said that the average physician interrupts a patient for the first time within the first 30 seconds of that patient speaking, okay? And the other thing that it said is that often the first complaint that the patient offers is not the chief complaint and not the most severe complaint. So in other words, if I assume I know what you're talking about and I cut you off in 30 seconds, guess what? We might not even get to what's really bothering you, right? And it's the same thing here with this diagnosis. So a careful history is important. Do you have any of these occupational lung diseases? You know, did you have any exposure to coal, to asbestos, anything like that? Did you have a long history of pneumonia? Do you have any autoimmune diseases? And so what the stage that you're in right now is you're in the stage of finding out, are there any known causes, right? And the blood tests are all part of that, because the blood tests are what's going to show the rheumatoid factors and things like, you know, the autoimmune diseases. And you got to do a lot of blood tests for that. But the key to a diagnosis of IPF is to rule every single thing out. That's the only time, and with a open lung biopsy, is to determine that you have IPF. And the reason why, and this is very interesting, because the imaging studies, right, like a high resolution CAT scan, some of the different diagnoses have the exact same presentation on CAT scan, but they have different underlying causes. And so I agree with you 1,000%. Don't panic yet. It hasn't been that long. Your doctor, and just to let you know, any good ILD doctor, when you tell them their story about how you didn't get diagnosed, they're going to be like, it's what people do now. They throw shade, and rightfully so, because hopefully physicians will learn about it. Physicians have to be educated. And you know what? There's a saying, you know it, but it's primo non nocere. Okay, it's from the Latin. It means first do no harm, right? And the idea is that one of the most important things of knowing things is knowing what you don't know. So if a physician looks at you and you have something that they haven't treated 1,000 times in the past, they need to refer you out. And you need to get your diagnosis at all costs. So if nothing comes of your workup so far, meaning that they cannot find a known cause, my bet would be that they're going to do an open lung biopsy, and that's going to give you a diagnosis.
Noah, I do have a question for Mary Jo. I'd like to ask for her.
Sure.
Her question was, I got a diagnosis from Seattle U of Washington, but they were conflicted about IPF and PPFE. Maybe, would you get a second opinion? And by the way, I might add that Dr. Ragu is going to be our speaker in December at the PF Warriors in Dallas, Mary Jo.
Hold on, let me look up what PPFE is. Pleuroparenchymal fibroelastosis. Pleuroparenchymal fibroelastosis. Okay, so as you can tell, that's the first time I've heard that term before, okay? I don't know what it is. But if you're not sure if you have IPF, now here's a very simple rule. If you don't know if you have IPF or anything else in the world, so it's IPF on this side of the scale, and this is everything else, you go for a second opinion, okay? Again, for the simple reason that there's only 2 drugs for IPF. There's only 2 drugs for IPF, right? And I'm going to read about this other thing now, PPFE, because I've never heard of it. It's obviously rare, okay? But absolutely, you need the right diagnosis. And if somebody says, I'm conflicted if this is a feather or a knife, right? It's different if you stab yourself in the neck with it, okay? And same thing with IPF and any other diagnosis. I don't even have to know what PPFE is. I'm going to know later, but I don't even have to know. If they're conflicted and they don't have a clean diagnosis. Now, Mary Jo, have you had a open lung biopsy?
Mary Jo, you can turn off your speaker in your bottom left corner and
I
ask the
can hear
question.
you now.
I had a vat, but I had
You had a VATS.
right. It didn't have. I didn't have any honeycombing.
Okay. I'm not sure that that necessarily rules it out. Now, I would just say this. I would say yes. I would get a second opinion. I would go to people who do it more than the people who've already done it. You can't go wrong. This is a big mistake. If you get it wrong, it's a big mistake, and it's a costly mistake. So in addition to not wanting to be on the wrong medicines, you want to make sure you're on the right medicines, because only those will work. My opinion.
Okay, can I ask you one more thing?
Sure.
So everything I read in your book and other, sources tells me that keeping oxygen at 92 or above is very critical. Can I switch into that gear?
You can, but we'll get to it, but go for it. Yeah.
Okay, so both my pulmonologist that I see here in Montana and the pulmonologist I see at University of Washington, both are telling me as long as I'm above 88% when I'm ambulating around the house or doing anything, I'm okay. And everything else, that's part of the reason I'm going for a second opinion, is because everything I read says no, that I need to be above that.
I disagree.
Okay.
I'm not saying I'm right, but just to give you a tiny bit of background, I mean, I'm pretty sure I've done more of this than anybody else. I started treating IPF patients in 1995, okay, when I was 24 years old. And the reason why we started treating IPF patients was because up till that point, and I don't even know if it had the name. I don't even remember back that far, but I have to write to my mentor and find out if we even knew the name of it then. But the idea is that up until that point, patients would get referred for rehab and they would get rejected from all rehab programs, saying that they were too sick or the staff was too concerned about keeping them safe or their oxygen requirements were too high. And the thing is that, to me, that's like Alfred Hitchcock's Lifeboat, where you say, okay, you know what? You require too much oxygen. You're too sick. We're not comfortable treating a patient like you. Get out of the lifeboat, right? So we know what's going to happen then. But we didn't know what was going to happen if we tried to treat them. So I said to my mentor, Dr. Horacio Pineda, who is a great man, now retired to the Philippines, who I will always be grateful to, I said, you know what? We're sending these patients home to die, essentially, because there's no way they can do this on their own. We don't know if they could do it with us, but we know they can't do it on their own, right? So we said, what if we had patients who come in, they'd be resting at 90%, 88% on oxygen, right? And they'd stand up and all of a sudden they'd be at 65%. And it scares people, okay? It's very scary even for clinicians, okay? In addition to my 26 years as a cardiopulmonary physical therapist, I also have now 17 years as a New York City emergency medical technician, okay? So I'm used to seeing people in dire straits. And I became an EMT simply to practice running emergencies with people who are in dire straits, okay? So that when it happens to me, if it happens to me, I've done it before. I can stay calm with it, okay? Most rehab programs are not in that kind of position, okay? But we started seeing these patients, and you know what? At that time, people were only exercising with nasal cannulas, right? That's all they were exercised with. And a nasal cannula is really only effective up to about 6 liters per minute, okay? And people always say, what about the high flow cannulas? No, I don't believe in it, okay? I'm not saying there's nothing to it. There are people who have been successful with them. But for me, if you need more than 6 liters per minute on a cannula, use a mask, okay? And that could be, my preference is a non-rebreather mask. That's the one with the bag at the bottom, because when we do that, we're able to significantly increase the chances and the concentration of oxygen and the chances of keeping you saturated. Now, do I have a pen on this computer? Do I have any way to draw? So let me tell you why, in my opinion, 88% is not okay. This is the oxygen hemoglobin oxyhemoglobin dissociation curve. 100%, 90%, right? It's all pretty equal, right? It all looks about the same. Here's what happens between 90 and 88%. okay? So it's like saying, you know what, you're 10 feet away from the cliff. I want to take your photo. You can get within 1 foot of it. You can get within 2 feet of it, 3 feet, 4 feet. But if you take that 11th foot, you're going over the cliff. And that's the significance of 90%, okay? And a lot of times people make the mistake of recommending oxygen to people based on a false idea that if you give a CO2 retainer too much oxygen, they're going to stop breathing, okay? And it doesn't work that way, okay? And I know every time I say this, at least 3 or 4 people write to me and they say, you know what, I was on too much oxygen, I had CO2 retention, I went into a coma. I know that, but with interstitial lung disease, you don't have that same problem, because as compared to the obstructive diseases, 99.9% of people with interstitial lung disease, and particularly pulmonary fibrosis, don't have the issue of CO2 retention. And the other thing is that most people with ILDs, they don't, like people with COPD, they get a little bit hypoxic, and then they'll hover around 90, 89, 88, 87. Most people with ILDs and IPF, if they desaturate hard. And for me, I want to protect my brain. I want to protect my heart. Although I've been accused of not having either one in the past, I want to make sure that if I do, they have plenty of oxygen, right? Because what is the secondary effect of hypoxia? Anyone know? Bill, do you know?
Let me turn off my thing. I would think you pass out.
Well, maybe people with pulmonary fibrosis, okay, and even COPD, they develop this condition over time, and so the body makes adaptations. But what I'm talking about is that over the long term, chronic hypoxia causes pulmonary hypertension, right? One of the secondary effects of IPF. And every time you challenge your body and that pulmonary circulation squeezes, okay, you're putting an increased load on the heart, particularly the right side of the heart, which most people have difficulty with the left side of the heart. So when most people have heart disease, coronary disease, or a valve problem, 9 times out of 10, it's going to be related to the left side of the heart, because that's the high pressure side of the heart. But when you have a pulmonary disease, particularly one that squeezes the lungs anyway, okay, pulmonary hypertension is the problem, and that increases the workload on the right side of the heart, and the right side of the heart is not prepared for those kinds of pressures. So you wind up with distortions in the cardiac anatomy, you wind up with major valve problems, and that leads to right-sided heart failure over time. So I don't know who's saying, I think sometimes doctors don't want to worry you, and so they're like, don't worry, you're 88, that's pretty good, But again, think of the cliff. You only went 1 step over the canyon, To me, why stick with it? Why chance it, right? And the thing is that people need to use a lot of oxygen. We have patients, we'll give them 25 liters of oxygen with a mask. And that's more than 100% oxygen, okay? It's a ton of oxygen, but that's what it takes to keep them safe. And here's the other reason why. Most programs will limit your activity to keep you saturated. I hear this over and over again. I want to smack someone. I don't really, because I'm non-violent, but the idea is it's so dumb. It's so dumb. If every time you desaturate, I stop your activity, what do you need me for, right? Or if every time your heart rate goes to a certain point, I stop your activity or make you stop or this and that, or I tailor your workout so that your vital signs are okay. And when I say okay, I don't mean safe. It's safety is number one, but the idea is give you as much oxygen as necessary to do the greatest workout possible, because that great workout is your only chance at improving lung function. And everybody says you cannot improve lung function, okay? The word is getting out. Where people are, last week, a doctor from Lenox Hill Hospital told his patient, he said, I've been arguing with Noah for 20 years about whether or not you can improve lung function, right? Because the literature says people feel better from exercise, they can do more, they're less short of breath, but no change in lung function, right? So he said, it looks like Noah's winning this one, right? Because what do we do that's different than everybody else? We exercise your ass off, okay? I don't care what it takes. I will give you as much oxygen as you need. If I need 3 therapists to stand there and make sure you don't fall off the treadmill, that's what I'm gonna do, okay? Malcolm X, physical therapy by any means necessary. And whatever it takes, that's what you have to do. And the same thing with living with IPF, okay? You have to take this seriously, and it has to become the sole purpose of your life, okay? Now, I hear a question from Susie. It says, I thought I read that low O2 over time can contribute to decreased brain function. Yes, let me just delineate from one thing, okay? Let me just delineate between the 6 minutes that people talk about, okay? That's 6 minutes of zero circulation, right? So that's a cardiac arrest. So that means no blood is pumping, there's no circulation, and then within about 6 minutes, heart muscle, brain tissue starts to die. But that doesn't mean if you're 88% for 6 minutes, no. So if it happens once and you walk to the bathroom and you come back, not a big deal. But if you know your pattern, and your pattern is that you're gonna go to 85%, don't play with it, okay? Take as much oxygen as you need to stay in the 90s. And the reason why I say 93% is because most pulse oximeters have a plus or minus accuracy of 3%, right? So let's say your doctor says it's okay, 88%, and you happen to have a pulse ox with a -3. Now you're at 85%. Would your doctor say 85% is okay? Probably not. It's a slippery slope. And people use the term slippery slope a lot. In this case, it's a slippery slope because once you get below that 90 part, everything plummets. So that answers that question, I hope. Now, back to the list. So list number 1, getting the right diagnosis, okay? List number 2, getting the right medications, okay? Right now, there's 2 medications out. There's Esbriet and OFEV, okay? Let me dispel another myth about Esbriet and OFEV. So number 1, it's earth-shattering that these things are here. It's groundbreaking. It's amazing, right? For the first time ever, we have something that treats IPF. But I hear from patients a lot of times, I started the OFEV or I started the Esbriet, and I don't feel any better. Bill, can I see a view of how do I change my view? Because I want to see everybody. Okay, there we go. I was seeing myself. I know what I look like, and I'm not happy about it. Now I see everybody. Okay, so the idea is that Amanda Runnels looks a little stiff to me. Amanda, smile once in a while so I know you're listening. But the idea, I'm just kidding. It's a photograph. I'm just joking. But the idea is that OFEV and Esbriet, they are anti-proliferative agents, meaning that we hope that they're going to stop the progression of pulmonary fibrosis, but they're not going to make you feel better, okay, necessarily, okay? They're not going to improve your lung function, and they're not going to reverse the lung function. They're not going to reverse the scarring. It may stop it, and believe me, I told you about this pirate ship, right? So we need to stop the leak first, right? But stopping the leak does not necessarily mean that we're out of danger, and it doesn't mean that we don't have a whole lot of work to do now, right? And that's where lifestyle comes in. I can't give you the specifics of this right now, but I will be able to announce it in about a week. We're about to start a clinical trial with a major drug company and a major clinical center for ILD here in New York City. For patients that are stable on Esbriet or OFEV, what is the impact of rehab? And the beauty of this is that finally, we're going to be able to clarify what is the real impact. And it's going to be in quality of life, symptoms, and lung function, okay? And so far, you know my bias against the 6-minute walk test. I just saw the protocol this week. It says 6-minute walk test, and we're not going to do it, but we're hopefully going to be able to show that you can improve lung function in IPF. We may not change the disease process, but if the Esbriet or OFEV stops the progression, and here's another thing that I thought of this morning for the first time, right? Like we have this idea that that IPF is irreversible, right? Or that some of these ILDs are irreversible. And I would say that I leave a little hope out for the possibility that that's not actually true. And why do I say that? Because things don't necessarily reverse in 6 months or a year or 2 years or 3 years, right? So if there's no medication for it and people die within 3 to 5 years, maybe had we gone to that 6th year and included some of these lifestyle things like exercise and, you know, nutrition and stress management and all these other things, maybe would have seen some improvement and or reversal and or regeneration. And I don't want to get your hopes up, you know, prematurely, but I believe that maybe if somebody does live 6 years or 7 years or 8 years with IPF because of either OFEV or Esbriet, then maybe we can see improvement and or reversal, right? In New York City, restaurants go in and out nonstop. They open, they close, they open, they close, they open, they close, they open, they do $1 million worth of renovations. 6 months later, they're out. And there's a lot of research that shows that if they had, and they usually run out of money because they spent so much money on the renovation. And the idea is that research shows that had they, and they're busy every night, but they still can't hold up. So maybe, and the research shows that if they can make it past the second year, they make it and stay in business. And it's a similar type of thing that I'm hoping happens with IPF, which is that if we can make it past the third, fourth, fifth year, sixth year, seventh year, eighth year, and that may be possible now because of these medications, right? And maybe the lifestyle stuff can take over.
Noah? No, pardon me. But I've had several questions about exercise. One from Stephen in Victoria. She says, what is the information on the specifics of exercise? What's good to do, what to avoid? Is there any relationship between pulmonary disease and heart stress or concerns? And how does exercise impact all of that?
Yes. Next question. Just kidding. All right. So here's the thing. Here's specifics, okay? And when I say here's specifics, I'm speaking non-specifically about specific, because the key is that a program has to be specific based upon my evaluation of you, okay? Every person is going to be slightly different, but the principles are the same. So typically when people start to get short of breath, they find ways to avoid the activities that cause them discomfort. As a result, they stop those activities or they modify those activities, and their muscles decondition, their lungs don't function as well, their heart doesn't function as well. God bless you. And the thing is that they get short of breath at lower levels of activity. That's one piece of the puzzle. That's one piece of the puzzle. There's other pieces of the puzzle. The other pieces of the puzzle are that you often have a hard time taking in adequate nutrition to support activity and life, right? The other thing is that you burn an inordinate number of calories because you're working so hard to breathe. Okay, the other thing is that you get frequent infections. The other thing is you have stress and anxiety, right? And all these things contribute and they all play a role. So the idea behind Ultimate Pulmonary Wellness is that there's 5 components of it. So it's having the right doctor. 20% is medical. So, having the right doctor, taking the right medications, taking them properly, exercise, nutrition, stress management, relaxation training, and prevention of infection. They're all equal, okay? Everybody believes that 80%, the way that medicine works today, is that 80% is treated pharmaceutically, with medicine, right? And nobody, maybe they'll say, oh, try to get a little more exercise. No, the medicine is part of it. You get the right diagnosis, you get on the medicine, now comes the lifestyle stuff. You have to be as active as possible. So what we do here, in my initial consultation with a patient, I spend about an hour and a half to 2 hours with them, okay? I go through their entire history, piece by piece by piece. First thing I do is called the HPI-CC, CCHPI, the Chief Complaint History of the Present Illness. And the way I start that off is I say, what's happening? Or tell me the story, or why are you here? Or how can I help you, okay? I want them to tell me in their own words, yes, I would like a cup of coffee, Mary Jo. So the thing is that in their own words, what got you here? What brought you to this day in my office? How did you wind up here? When did your symptoms begin? Did they worsen? What was your diagnostic process with your physician? Okay, what medications are you on? I don't speak during that unless I have questions and I need to clarify with something. I know that's hard to believe. hearing me talk today. But the idea is that I want to hear the patient's perspective. How did we wind up in the same room together today? Okay. The next thing I do is I ask them about their medications. And by doing it this way, when I find out their medications, it allows me to find out things about them that may have been missed in the first part, right? Because you come to an appointment, you're nervous, there's a lot at stake here, it's a new place, new people, you may forget things. And for that reason, I recommend before you go to the doctors, bring all your information with you, okay? Have it organized, keep a diary so that when you go there, you don't walk out the door and say, oh man, I forgot to mention this, okay? Then I go through my systems review, and my systems review is literally system by system by system. I ask them things that they may not have thought of. So do you have any neurologic problems? By that I mean, have you ever passed out, dizziness, stroke, seizure? Do you get a lot of headaches? Do you cause other people a lot of headaches? Is your hearing okay? Do you have any nose or sinus problems? And through that, I know I'm going to get everything, okay? People don't often take a good history. You want to know how to take a good history? Watch Gregory House, MD. Watch the television series. I learned so much from just watching House MD. It sounds funny, but you learn how to do the differential diagnosis. And if you watch it, you know that when they're writing all these different diagnoses on the board and crossing them out as something rules itself out through test result, finally there's one diagnosis left, and that's how ILD needs to be diagnosed. It can't be diagnosed by symptom, chest x-ray, PFT, sometimes not even by CAT scan, but even with the open lung biopsy, it's not always clear, okay? It's not always 100% clear. So they have at, certain hospitals, they'll have ILD boards where a pulmonologist and a surgeon and a radiologist and all these people get together and they say, well, this is what we have. What do you think? What do you think? What do you think? What do you think? And they narrow it down and they narrow it down, they narrow it down. I know we're talking about exercise still, okay? We're definitely still talking about exercise. Now, here's another thing. The next thing we do is we do an exercise tolerance test, okay? Now, most people will do a 6-minute walk test, right? To me, 6-minute walk test is next to useless. Next to useless. I said it, okay? I've been fighting with people 20 years about the 6-minute walk test. Why? Why? It's patient controlled, right? So the patient can make themselves walk faster or walk slower, depending upon how symptomatic they want to become, right? They can determine if they want to take a rest break or not. They can determine, I'm really going to go for the gusto here. I've actually heard people say this, if I do too well on this test, am I going to be kicked out of rehab, right? Or if I do too well on this test, well, what should I do on this test? I need to get oxygen. What should I aim for? No, you've just influenced the test. You've just biased the test. The test is useless. And I feel like cursing now, but I won't because I see a lot of ladies in the audience. So I'll hold my tongue, okay? But the other thing, okay, depending on who the person giving the test is going to change the result, right? Because somebody might be going, hey, come on, go, go, go. And you're going to be like, or they might just be like texting, hey, I wonder what my boyfriend's doing. And you're like, is this person even paying attention to me? Same thing with PFTs, right? There's research that shows who is giving you the test. You could always tell where the PFT lab is in the hospital, right? Because you hear somebody going, blah, 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 blah. And you're like, what's going on here, right? But that has been shown to influence the result. So if you get a shitty result, sorry I cursed, if you get a crappy result, everything you do from that point forward is useless. Everything you do from that point forward is useless, right? So you have this 6-minute walk test. The hallway or the track or the area that they use to do the test makes a difference on the result, right? Because if I have someplace where I can continuously walk, that's different than if I have a 20-foot hallway and I spend half my time turning my oxygen around, right? All these things make a difference, right? It's also flat surface, right? How many people have trouble on an incline before they have trouble on a flat surface, right? So that test completely eliminates that factor from getting any information. Useless, okay? And I don't care. That usually when I say something like this, the gods of pulmonary disease call me up. They're like, hey, I saw what you said the other day. You need to be quiet. And it's like, no, that's the truth. And I say it all the time. You want to randomize some patients and see who gets a better result? I'll put my money on my team anytime. And it's because we get the right tests with the right result, okay? Now, here's the other thing about it. Most are not monitored, right? Maybe you carry a pulse oximeter, right? Sometimes they just spot check you. Sometimes they get a reading before the test and after the test. So if we want to know how our plane handles altitude, taking the readings on the runway before we get off, and then again after we land with nothing done at 20,000 or 60,000 feet, I don't know how high a plane flies, is useless, right? And if you get in trouble only when you walk uphill, then walking you on a flat surface is useless. If you get in trouble only when you walk stairs. So we have to have a test that accounts for all these things and the incline and the speed and monitors you throughout. The other thing is that a lot of programs will not use EKG monitors, okay? When I opened my program 20 years ago, people said, hey, you know what? You don't need an EKG because you're dealing with pulmonary patients, right? Stupid, dumb, not thinking, right? Because here's the thing. Many people with pulmonary disease also have heart disease, right? But it never gets diagnosed. Why? Because they're limited by their symptoms of pulmonary disease before they're able to have any type of hemodynamic response, right? So maybe if I didn't have this pulmonary disease and I was able to walk up 1/2 a flight more, maybe I would have had angina, right? And here's another problem, okay? Once you get a diagnosis, very often you become that diagnosis. You're no longer your name, you're no longer your person, you're IPF, right? And everything gets attributed to IPF or everything gets attributed to COPD. I have people ask me, is foot pain a symptom of COPD? Sometimes people will try to explain why it could be. Well, you know, if you're short of breath and you're not walking so much and then you walk and no, you got to know what's what. You got to know what is and what isn't. And don't attribute everything that happens to you to your one disease, because people have more than one disease sometimes, right? And we have to be looking for things that are non-specific. I talked to you before about non-specific symptoms. So shortness of breath, cough, chest pain or pressure, squeezing feelings, palpitations. These things can be related to your lung disease, but they could also be related to something else.
No.
So, yep.
No, you have several questions in your chat area. Also, one from Richard Kraft, which I thought was kind of interesting. And I'm not sure you're aware of this or not, but is there anybody in Dallas that's adopted your philosophy of rehab?
I don't know. I think you have. I don't know. I mean, I can't, let's put it this way. I can't tell this story and remain, I'm going to tell this as a generic way. I went to a rehab center, a pulmonary rehab center recently. And I walked in and it was pitch, like you could hear a pin drop. That's how quiet it was, okay? And there was one therapist and one patient, and they were doing things like this. They were saying, okay, raise your arm up and down, and raise your other arm up and down, and both arms up and down. And when I shared our philosophy with them, and when I shared our exercise testing protocols with them, and I showed them our results, their minds were blown. They were like, it was like I just told them the earth is not flat, okay? And a lot of times people are skeptical of our methods, but you know what? I have the proof. I've been doing it for 26 years, and I can show you what it looks like. I could show you what it looks like to have a 95-year-old man walking on the treadmill at 3.5 miles per hour with a 15% incline. I post those videos all the time. Because I want people to understand what is possible, and not to say it's possible in every single case, okay? But what you should be aiming for, Okay, so as far as do I know anybody who's specifically adopted my program? No. And we, we are available. We have a program called Pulmonary Wellness, the Blueprint, where we train other professionals and we train other rehab centers. And the idea is that everybody's got to learn this. And I'm hoping that this clinical trial is our gateway to really getting other people to not be afraid to adapt these protocols. And if it means we go to your rehab center for a week or so and teach you while we're there so that if something does go wrong, we're with you at least, that's my goal. But the idea is with the exercise testing, everything is done on EKG, blood pressure, oxygen, okay? We do a treadmill test, not like the treadmill test that they use for diagnostic testing, which is a very vigorous test that starts at 1.7 miles per hour, 10% incline, but we start at 1 mile per hour. And instead of going up, the other problem with the diagnostic test is it's not linear. So it doesn't go up evenly. It goes up huge, then a little less, then it also doesn't make sense for pulmonary patients, right? Because very often the limiting factor with pulmonary patients is not their heart. It's not a cardiovascular or hemodynamic problem. It's shortness of breath and or lower extremity leg fatigue, right? So a lot of times patients have to stop the treadmill because they're short of breath or their legs are tired long before we see any hemodynamic response. So a lot of times I get these exercise test reports where they use a treadmill protocol that's too vigorous. And what happens is they say patient exercised for 12 seconds, negative for heart disease. You can't get any data from that. It's 12 o'clock now. I just want to say this. I know that we were supposed to be stopping now. I'm just warming up. So if you want to stay, I will stay, okay? When I was in Dallas, we did 2.5 hours. But I'm fresh as can be. So if you want to stay, stay. If not, have a great day. But if Bill's okay with that.
Those that are having to leave, thank you for coming in. I think this has been just a great, great session. And Dr. Greenspan, I'm always overwhelmed with your depth of expertise and your insights and ideas, always. This has been super. Stick around. I'll hang with you as long as you like to hang. If you want to sit in and ask questions, I would encourage you, because many of you have questions. If you have a question, turn your mic on and ask it. Dr. Greenspan's he'll answer it.
Explain this final concept, and then I'm going to go to all questions for the next hour.
All right.
Okay? So the idea is also that when you talk about exercise testing and prescription, a lot of times you hear these terms like you should exercise at 60% of your maximum, right? But as I just told you, the limiting factor is often not hemodynamic. It's shortness of breath and or leg fatigue, right? So let's say that stops you and there's this thing called MET levels, which are metabolic equivalents. So let's say because of your shortness of breath, we have to stop you at 2 METs. If I then take 60% of that and put you at 1.2 METs as your exercise, that's like sitting in a chair, drinking a margarita, and not even lifting it to your mouth, sipping from a straw. So it's almost no exercise, right? So in the pulmonary patient, all of these target heart not the same as a cardiac patient, okay? What you do is we give you a maximum heart rate, and it's usually based on your age, okay? But it's not 220 minus your age, which people know. It's 200 minus your age, and we will let you go. Not to say we're shooting for that, but if you're 60 years old, we'll let you go to about 140 as long as everything else is okay. And when I say the way that we know that everything else is okay is we have you on an EKG the whole time you exercise. So I'm looking up at a screen that looks like this right over here, okay? Everybody's EKG is there. And the thing about that is that we're continuously seeing your EKG, your heart rate and rhythm. And I said before that everybody said we don't need EKG monitors. In 26 years and in over 100,000 exercise sessions, I've sent about 100 people to the emergency room, okay? So I know that sounds like a lot, but it's 1 out of 1,000 exercise sessions. That's not a lot at all, okay? But in 95 out of those 100 cases, it was always the EKG that told me there was a problem before the patient was even symptomatic. That's why I think all cardiopulmonary rehab programs, even if they're just pulmonary, should have EKG monitoring. And I know there's going to be people say, you don't need it. If you don't need it, if you feel you don't need it, then in my opinion, and it's not always a popular opinion, but in my opinion, you're not pushing the patients hard enough. And if you're not pushing them hard enough, then you're wasting everybody's time. You have to get the maximum amount of people. And in order to get the maximum amount of people, you have to do the right test. You have to provide the oxygen, as much oxygen as people need. And then you need to push them and see what they could do. And so what we do is within 3 sessions of seeing somebody for an exercise test, we want them working out at 100% of the level they achieved on their exercise test within 3 sessions. Okay, and then so there, now we're equal, right? Everybody else would have had you down here. Now we're going to go way up. And that's why our patients have 50, 75, 100%, 110%, 130% improvement in aerobic capacity because we push you, okay? Your body gets good at doing what you ask it to do. So if you ask it, if it feels easy, if it's not that much strain, if it's all good, it's not going to help you that much. All right, questions. Bill, do I have to read this list, or do you want to read questions?
I think we have a couple of different things, Noah. One is we've had a number of questions that have been asked that you have in front of you, text messages. And secondly, I think a lot of people are sitting there with great questions they'd like to ask. So
go for it.
I'll leave it up to you. I'd say do both.
Okay, go for it. I'm ready.
Noah,
yes.
I have been on it. You want me to go?
You're there.
I hear you.
Oh, I have been on pulmonary rehab for 2 years. I still don't get my heart rate up where I think it needs to be. I rarely get above 90. I feel like I could do better than that, but for some reason I'm timid about really pushing myself. I am on 2 liters of oxygen with exercise. Should I just bite the bullet and go ahead and push myself because I am in a medical facility doing this? I don't know why I can't get the maximum out of what I'm doing, but I don't feel I am.
Okay. The answer is maybe. Next question. No, I'm just kidding. So I have a few questions for you. So stay off mute. Number one, I'm going to ask the rudest question first. If we get by this, then we're good. How old are you?
72.
72, and your heart rate never goes above 90.
Right.
Okay. Are you taking any medications that could potentially create a ceiling for your heart rate, such as a beta blocker, metoprolol? You are.
Inderel.
Okay, so Inderol is propranolol. Okay, so in a case of somebody who's on a beta blocker, okay, what I said before about 200 minus your age goes out the window, right? Because what a beta blocker will do is a beta blocker is going to create a ceiling above which it's like a limit to your speakers. Okay, it's like if you don't have the right speakers, no matter how high you turn up your receiver, you're limited by your speakers. So that's one thing. So first of all, you're taking Inderol, which is propranolol beta blocker. It's going to lower your heart rate, going to lower your blood pressure. So forget the 200 minus your age. Now we have to use other factors to tell us how hard you're working, okay? And the simplest way of doing it is the Borg scale or the RPE scale, right? One mistake that I think people make is they give people, and personal preference, I use the one that goes up to 20. I don't think 1 to 10 does it, okay? But I don't think the numbers are the important thing there, okay? A lot of times somebody will give you a scale and they'll say, are you working very, very light, fairly light, somewhat hard, hard, very hard, or very, very hard, right? Now, by the time I get to that list, you've forgotten the beginning of the list, right? So I start off with what are most people working at, right? And most people are working either fairly light, somewhat hard, or hard.
Right.
So if I would advise clinicians to just ask that question first, are you working out fairly light, somewhat hard, or hard, right? If somebody says, I'm working out fairly light, because we want your workout to be in the fairly light to somewhat hard range for most of it, and we want it to be hard at the peak, right? So it's like a flight. We want it to be fairly light, somewhat hard. Here we are, it's hard, and then we have a nice gradual cool down. But I would say ask, are you working fairly light, somewhat hard, or hard? And if the person says I'm working fairly light, my next question is, are you working fairly light or very light? And if they say fairly light, then I know exactly where they are. Right? Makes sense? Without giving you 6 to 20. Incidentally, the other reason why I like the 6 to 20 scale, I love when the cardiopulmonary system intersect and make sense, because that's why I love the systems. I love the systems. And 6 to 20, think about this. There's an interesting fact. This became the Borg scale because they were doing the testing on 20-year-olds, right? So a 20-year-old at rest should have a heart rate of 60. Right? And if we take 200 minus 220 minus your age, a 20-year-old at peak exertion should be at 200. 220 minus your age. That's where 6 to 20 comes in. So 6, 60, 70, 80, 90. So I would ask you, are you working fairly light, somewhat hard, or hard? If you say fairly light, okay, we're going to work you into the somewhat hard range. Okay? If you're working somewhat hard, cool, stay there for a little while. When you feel up to it, we'll bring you into the hard range for the peak, and then we'll bring you back down. But that is not the only factor. You have to take multiple factors into account, and that's where oxygen saturation comes into play. And again, I recommend people bathe their bodies in oxygen, take as much as you need to remain saturated, and also blood pressure, okay? A lot of times people ask me, like, or I'll say it without being asked, but I like saying it because it's an interesting fact. Like, if I only had one vital sign and I had to make decisions based on one vital sign, it would be systolic blood pressure. Why? Because systolic blood pressure is a function of heart rate and stroke volume and oxygen and all these different things. So if your blood pressure is okay, and just as a point of reference in our center, and again, these are general guidelines, but of course there's going to be people who we have to, make exceptions for and more specifically tailor our parameters. But as a general rule, if you're under 80, we'll let you go to 200 systolic blood pressure as a maximum. Again, it's not our goal, but it's a maximum as long as you don't have heart disease, as long as you don't have heart failure, as long as you don't have aortic stenosis. And if your team doesn't know it, they should have the book, Guidelines to Exercise Testing and Prescription by the American College of Sports Medicine. And there's only 2 pages in it that they have to know. Contraindications to exercise testing and indications for terminating an exercise test. And that will tell you everything you need to know about what's okay and what's not okay. You memorize that, okay? They have to study it. Not you guys, but give it to your team. Tell them they need to get this book and memorize these 2 charts, because that's going to guide you further. So don't worry about your heart rate, because we've already established that because of your Inderal, it's not accurate. Blood pressure, RPE, oxygen saturation. And push it, yes. Okay. If you're only working out fairly light, you're not working out hard enough.
Right. I don't think I'm
a lot of places you go, the patient's in control of their own workout. So they'll ring a bell and, you switch machines, right? But nobody ever comes over to you. Or you'll have, 1 clinician or 2 clinicians and 15 or 20 patients, because that's what the guidelines allow. That's not enough. We do 1-to-1 or maximum 1-to-2, and every 3 to 5 minutes, we're checking oxygen, we're checking blood pressure. And we're making these, it's like you wouldn't set your car to go 90 degrees north, right? You're going to make these adjustments based upon what you see. So if there's something in the road, you go this way. And we do the same thing with exercise. And that, by doing it that way, every minute of every single workout of every rehab program gives you the most bang for your buck. Otherwise, it's like you have a cup, you're only getting half a beer.
Mm-hmm. Mm-hmm.
Does that make sense?
Yes. Absolutely.
But ask your team, say, these are my concerns. This is what Noah said. What do you think of this? And let them monitor you a little more closely while you push yourself the first few times.
Yeah. And they're great at this center. They will keep an eye on you very closely.
And let them do it, because that's the only way you're going to get better.
Yeah. Right.
And another thing is that, again, I spoke of MET levels before, right? So MET levels are metabolic equivalents, and every single thing that we do during the day has an equivalent metabolic equivalent. And the idea is that if your life requires 7 METs, and I'm just speaking theoretically now because it is a complex concept, but if this is what your life requires, and I exercise you down here, you can do that till the cows come home. Your life never gets any better, right? So if this is what your life requires, and I could teach you the breathing techniques, and I can gradually build you up, and I can give you as much oxygen as you need and exercise you up here, guess what? Now your life is better.
I've been told to do intervals.
Intervals are great, but what we do, we'll do 5 minutes, increase it. At 13 minutes, at 10 minutes, we increase it again. At 13 minutes, we come down a little bit, okay, to reset the heart rate, blood pressure, oxygen. At 18 minutes, we go up again to an even higher. So it's like level 1, level 2, level 3, come back down to level 1, then level 4.
Oh, those are long intervals.
What, 5 minutes, you mean?
Yeah, to me, I've been doing 2.
2 minutes is not enough time to reach a steady state. It takes 3 to 5 minutes for somebody to reach a steady state. So you're actually pushing yourself more towards anaerobic metabolism by doing it that way. You're actually increasing your lactic acid production by building up too quickly. Next question.
Noah, I'm Michael Wecker. I'm 60 years old, and about a month ago, I got diagnosed with IPF from a high contrast CT scan. It showed just very shadows on the outside of the lung. My mom has IPF, and she's been on Esbriet. I am not. Are you a fan of starting it immediately? Because my doctor said, come back in 3 months and let's reevaluate it.
First of all, I'm not a physician, okay? But here's the beauty of my work is I work with all the physicians in New York City. So I get to see what everyone's doing, okay? My personal opinion is this. If you're sure it's IPF, get on the medication yesterday. If you're sure it's IPF, don't wait, okay? Why wait? Why wait?
Right.
If you're sure it's IPF, you haven't had an OLB, right? You haven't had a lung biopsy. So if you're sure it's none of the known causes, right? And you've been ruled out for NSIP, non-specific interstitial pneumonia, and you know it's IPF, why wait?
Fair enough. Thank you very much.
Why wait to put the Band-Aid on?
Right. Thank you.
Yep. Next. Should I read from the side?
No.
Yep.
No, this is Dick Morgan.
Yep.
I've got 2 things. I've been living with heart disease for 30 years. I've got 4 bypasses. I had a heart attack on the back side of my lungs.
Bypasses. You mean you had a cabbage times 4. You had a quadruple bypass, right?
Yes.
Not 4 separate bypasses.
Yes.
Okay.
And the heart attack was on the back side of my heart. The right, I understand, the right-hand side was not the other.
Right.
So it concerned me a little bit. You said the right-hand side is not the one that takes most of the work.
Right.
So I've got that to consider along with pulmonary fibrosis. And I've been through rehab at Baylor. They didn't work me very hard, but they taught me a lot about breathing. I found out after this many years, I didn't know how to breathe properly. And so they helped with that. But my limitations are not so much breathing related as they are, my legs, also heart rate. So I'm kind of in a balance, or trying to get a balance between what my heart is happy with and what my lungs are happy with. But a lot of what you said gives me cause for a little pause, because I do have to consider the heart part and the fact that I'm on a beta blocker, have been for years. And I've got somewhat of an enlarged heart and a little bit of a valve problem, I understand. So I'm going to have a long talk with my cardiologist once I get a second opinion on the IPF. But am I right that I've got to be concerned with both heart and lung at this point?
That's your question? Yes. Next question. No. All right. So let me tell you my thought process and what you just said. Okay. This is the things I want to know. A, when was your heart attack?
1988.
Okay. B, when was your bypass?
1988. Same month.
Okay. So here's the thing. Somebody who's had a heart attack is at more risk for a second heart attack than somebody who's never had a heart attack before.
Right.
That being said, your heart attack was the year that I graduated from high school. Okay. You didn't have another heart attack since then. I consider that ancient history. Okay. So that bone is healed, right? Because what happens when you have a heart attack is you develop some scar tissue on the heart, and that can affect the mechanics of the heart. Now, here's why I'm going to completely contradict the statement that I just made, okay? When somebody has a bypass, okay, if somebody comes to me even 2 weeks after quadruple bypass surgery, I love that person. Why? Because they have 4 fresh, clean pipes, right? Unless something went drastically wrong with the surgery, that person's not having a heart attack no matter what, okay? But for the person who's had a bypass 10 years ago or more, really, okay, there is a risk of reocclusion, right? The bypass grafts, the grafts can occlude and develop atherosclerosis in the same way that your native arteries can as well. But I'm assuming that your doctors are watching that and that you've at least had periodic angiograms, correct?
I've had stress tests, the thallium stress test every year. I have had,
okay.
6 years ago, I had a couple of stents put in. Otherwise, I've been okay.
Okay, so that's a booster, right? So you have the nuclear stress test every year. I guess 6 years ago, they found that there was some more ischemia, and you had stents. So that's opening them up again, okay?
Right.
So the idea is that you're on top of your coronary disease, okay? You have a good cardiologist, I hope, and
You bet.
monitoring you very closely. And so there's that factor. So you should not be ischemic, and there are also medications that can help reduce the ischemia, okay? Ischemia means hypoxia, meaning that your heart muscle is not getting enough oxygen, right? And how your body uses oxygen is based on 3 things. Number 1, how good are your lungs at moving air in and out? You have a strike there. How good is your heart at pumping blood? You may have a strike there. How good are your muscles at using oxygen? So absolutely, is it something that we have to pay attention to? Yes. Is it something that precludes you from doing vigorous exercise? No, but you have to do it under the right conditions where your EKG is monitored, where your blood pressure is going to be monitored. There are symptoms, there are signs that your heart is not doing what it needs to do when you exercise. So in that table that I said before, a drop in systolic blood pressure. So when you exercise, your systolic blood pressure is supposed to go up commensurate with the level of exertion, right? So if you're going up, 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 and your blood pressure is going up, up, and then all of a sudden it goes down, and you feel dizzy and you get sweaty, and we see something on your EKG, then you know you've overdone it. You don't want to get to that point. You want to do it gradually. The other thing is that you had a posterior heart attack, and that's the back of the heart, and that's usually the right side of the heart. And the good news about that is that the left side of the heart is the pumping side of the heart. It's the high pressure side of the heart. The bad news about that is that, you know, you have to pay a little bit more attention to it because of your lung disease, right? So we have an increase, we could potentially have an increase in pulmonary artery pressure, which would further increase the workload on the right side of the heart. So my recommendations to you would be, and you know what, if you want to do this, I'm willing to help you with this. I'd love to read your reports, and then I could give you really clean information about what you should try. But the idea is, you mentioned the valve. Do you know which valve it is?
No.
Okay, So you need to know which valve it is, because in 95% of the population is going to be either the aortic valve or the mitral valve, which are the two valves on the left side of the heart. And the reason why they have so much problem is because they have the most wear and tear. If it's either your pulmonic valve, which is the pulmonary valve, or your tricuspid valve, which are on the right side of the heart, then it's something to think about, because that can potentially contribute to also increasing the workload on the right side of the heart. And you don't want to develop any type of right-sided heart failure, okay? But if your coronaries are relatively clean with interventions or not, so meaning the bypass, the stents, and you get those checked regularly, my inclination would be to push you under the right circumstances.
Okay. Thank you.
Sure thing. All right, let me read some questions. Do I have any miracle patients like Bill Vick, who is winning marathons? I wonder about Bill Vick. I have to say that. There are certain outliers, okay? And I'm not sure about Bill Vick, because Bill, if I'm not mistaken, you're not on any medications, are you? Or are you now?
I stopped both medications. I was on Ofev. I was on Esprit. I stopped both.
Can I ask why you stopped?
It wasn't a personal decision. It wasn't worth it to me to have the side effects and lifestyle impact when I had to buy another 6 months of life. It just wasn't worth the exchange.
You're talking about the GI side effects, right?
You got it.
Yeah. That's a real decision right there, okay? It's a personal decision. Okay, it's like
but you know outliers like Russell Winwood that although he's COPD, he's got, what, 27% lung capacity running marathons.
I wonder about him too. I think there are things unknown.
Maybe.
I think there are things unknown, and, you know, I have my feelings about what's going to happen in the future, and I would never share them with anybody, because although I am a sorcerer, I can't be sure, and I don't want to, you know, throw shade on anybody, but there are some things that are unknown, for sure.
Of course, in all of our lives. I've maintained the paleo diet. I've maintained an aggressive exercise regimen, and I think those lifestyle things, at least for me,
Spade, right?
Yeah, it's been a life-changing experience, and really? I see others that follow the same regimen that also have success and have extended their lives. Best that 3 to 5 year thing. I'm 7 years and still stroking. So
that's why I wonder about you. I find you a fascinating specimen. And the thing is that I can't explain it. I mean, maybe it is those things, you know, maybe it is. But I also know people who do all those things and their disease still progresses.
Yeah.
So you are a unique individual, as is Russell. As are some other people.
Terrell McBride, and there's a number of people that are doing well.
Again, they're individual cases. I know people who, you know, I don't know. I mean, you made a personal decision. If it were me, I mean, I don't know what I would do. I can't say. But I hope someday, what the medications are going to, the way that they'll improve is by eliminating those GI upset, because I know they're brutal.
But your clinical trial you're going to be doing on pulmonary rehab, I think, can be one of the solutions in spelling this lifestyle approach of, and your focus is exercise.
Yeah.
We had Ed Walisky, who's a doctor, who got off, by the way. He had to leave for a birthday party, but he was diagnosed 6 years ago. And he has after tons and tons, and I spent an hour with him the other day talking on the phone. He really has a snapshot of living with the disease using the ketogenic diet plus a Chinese herbal medicine approach.
I'm sorry, which diet?
Ketogenic.
Ketogenic, okay. I thought you said catatonic for a second.
Yeah, it's like that, I guess. But I don't follow that personally. It's a little too strict for me. But he's done some remarkable things. At some point, I'm going to ask him to engage with you and talk to you, because he's got some insights of great depth. He's a medical doctor. He runs a big practice up in Denton, Texas. And he's a patient, and a very open, astute, and smart one.
I'm going to tell you what I don't love about keto. Okay, and I'm not going to rail keto for 20 minutes now, but I'm just going to say this. I think that it is I'm all for low carb. 100%. We've been talking about that for 15 years. Why? Because the byproduct of carbohydrate metabolism is CO2, right?
Sure.
That's bad for you. But the reason why I don't love keto for people with respiratory disease is because one of the ways people get into real trouble, and I mean kind of like the final frontier of failing with respiratory disease, is that they have an exacerbation or something comes up that just wrecks them, and then it's hard for them to gain weight back. And with keto, I think people become a little too lean, and I want people with particularly IPF more than the obstructive diseases to have some cushion and prepare for a rainy day. And I think keto is way too restrictive. And, you know, I know people will swear by it. I definitely know that, and I can't argue with success. But for the general patient, I want people eating a lot of healthy fats. I want them to eat healthy proteins and, you know, work on calories, but getting those calories through fat. And you have to have some carbs. I think it's my opinion. Like I said, I've seen hundreds, if not thousands of people with IPF. And I don't see that as being the best solution. My opinion. Can't hear you, Bill.
There we go. Yeah, I'm sorry. I said that's exactly why I follow the paleo diet and not the ketogenic diet.
Paleo is much better. You know, I think keto, you know, again, I think a lot of the stuff is anecdotal, and I don't want my patients, especially my IPF patients, getting too thin. Okay, because again, it's like you don't go on a vacation with $5 in your pocket. You need to have enough of a cushion that if something goes wrong, if everything goes wrong, you're still okay. And you know, again, it's that final straw that breaks the camel's back, and very often it's related to nutrition and you know, metabolism, because you know, when people have an exacerbation, they're working so hard to breathe and they're burning so many calories that for some people, it's like you're bailing out the boat, but it's coming in so fast that you don't have a shot. And so I want to make sure that if something goes wrong, don't worry about your six-pack abs, okay? If something goes wrong, I want to know that we have a life jacket with us, and that life jacket often is a little extra fat.
Noah, you spoke to exacerbations. Do you have any thoughts on what are some good healthy things to do to avoid? I know that you can't avoid them.
I do. I have a lot. And there's a chapter in my book all about prevention of infection. Okay, it's a whole chapter on it. My book is available for purchase, but it's also available to read for free on our website if you don't want to buy it. But there's a whole bunch of things. Okay, and the other thing is there's another chapter on it's called Zen and the Art of Secretion Clearance. And there's also webinars on our website about these two topics. I think prevention is the key. I think being aware of your surroundings, who's around you, who's sick, who's not sick, what you're touching. You know, was Typhoid Mary on the train before me, and now I have it on my hands, and I'm bringing it to my face. But also, although it's less common with people with restrictive and interstitial diseases than with the obstructive diseases, if you have secretions and mucus is a problem for you, then you need to be doing something daily in terms of secretion clearance, whether it be an aerobica or an acapella. And I saw somebody before using their acapella as they were doing this. But yeah, I think it's regular secretion clearance, regular airway maintenance, and regular pulmonary maintenance. And, you know, being aware of your surroundings, frequent hand washing, getting the flu shot, getting the pneumonia vaccine, getting the shingles shot, you know, preventative medicine, and then getting the right nutrition, because nutrition is key in terms of health. There's this, you know, there's supposedly 90 vitamins and minerals that you need to support life. And we're working on something. I hope to have a product available within the next 12 months that's going to be a supplement for people to make sure that they're getting all those things. there are people who believe that you can get all your nutrients from diet alone. Here's why I think it's not true, okay? You might be able to believe that. Okay, so Gene just raised his hand and said you can. Let me tell you an interesting reason why you might not be able to, right? So I buy this juice from a place called the Juice Press, right? I assume that the Juice Press is doing their due diligence in terms of getting me the best juice, the best quality juice, right? I assume that Juice Press is trusting that their farmers are doing their due diligence in terms of providing them with the most nutritious products, right? But think about it. There's a concept related to topsoil. And, you know, farmers grow crops in the topsoil. And very often when they want to grow something, they add topsoil and they, you know, fertilize topsoil and add all the things that you need to have healthy growth. But when times are not so tough, maybe they're not rotating as much, or maybe they're cutting down on some of the fertilizer or this and that, right? So if you have something, it could be the healthiest food on earth. What's the healthiest food on earth? I don't know. Blueberries, you know, think of the superfoods, right? If they're grown in soil that's completely devoid of nutrients, then you're not necessarily getting it. So I won't argue with you and say that you can't or nobody can, but I think there's room for improvement. And the thing is that, again, similar to what I said about the OFAV and the Esbriet before, don't get the idea that you started taking a supplement and in a week you should feel better, right? Because for all we know, you could have been deprived of a vitamin or a nutrient or a mineral for years. And it's going to take time for that to grow back and regenerate. And, you know, we don't necessarily know where our deficiencies are. So I think that there is something to that. I think you have to supplement. But, you know, again, back to the question of prevention of infection, all the things of ultimate pulmonary wellness. So take your medication right, exercise, make sure you're washing off the machines. In rehab, you know, they also need to be washing the machines very frequently. In between every patient, they should be cleaning machines, right? Wiping them down. If they don't, then bring your own wipes and all those things. But it's in the book.
Noah, we have one of our members, Linda, who has a question to ask.
Okay.
Hi, Dr. Noah. I was diagnosed with IPF 2 weeks ago. The pulmonologist did not recommend pulmonary rehab, so I'm making my own program by watching YouTube videos and going to the gym and using a treadmill. I'm 74 years old. I can walk between a half a mile and a mile without any problem. I want to get a second opinion at the UCF lung program, but I wonder if I should ask or just wait. He wants to give me another PFT test in November and see if there's another decline. He said he's 85% sure, but he wanted to give me a biopsy, but I told him I wanted to wait. What should I do? Should I ask him for a second opinion? And is it okay to be doing these pulmonary rehab videos? Because they sure are good, some of them. And I really enjoy doing it.
Maybe. Next question. Again, I don't know. You know, it's possible. But again, what I would say to you is maybe it is okay, maybe it's not okay. If you have undiagnosed heart disease, then it's probably not okay. If you have an undiagnosed aortic aneurysm, then it's probably not okay. If you have undiagnosed aortic stenosis, then it's not okay. First order. What?
Excuse me. I do have an aortic aneurysm, but it's very small, and they just want to watch it and do another CT scan in a year.
Okay, so you have an aortic aneurysm. The thing is, it's small, but here's the thing. It's going to be pressure affected, right? So you ask, is it okay for you to do exercise? I don't know, because if your pressure goes up to 220 over 100 when you exercise, then that aneurysm may be small. Like I have this balloon, it may be small, but if I squeeze it hard enough, it's going to burst, right? I don't say that to scare the hell out of you, okay? That's not what I think is going to happen. But when it comes to an aortic aneurysm, if something goes wrong, you've got seconds to minutes, okay? So the idea is the first order of business I would want from you is I would want a cardio, a stress echocardiogram. Okay, because what that's going to do is it's going to see what can, and if you can't walk on a treadmill very well, then I would want it to be a pharmacologic test, right? So the purpose of a pharmacologic test is that if for the person who gets too short of breath or the person who can't walk enough to really see a hemodynamic response, the pharmacologic test mimics exercise and does the work for you. So it's going to increase the contractility of the heart. It's going to increase the dilation of the coronary arteries. And then that's the vascular component of it. You also have an EKG on, so that takes care of the electrical component of it. And then you also do an echo while, immediately before and immediately after the test. So that takes care of the mechanical component of it. That should be able to tell you what's safe and what's not safe. So in your case, I want that done before I even begin exercise. And then I would read your reports, and based on what's seen there, I would make my decisions as to what's okay and what's not okay for you.
Okay. That's called a what kind of test again?
A stress echo.
Stress echo.
And if you can't do enough on the treadmill to do that, I would ask for a nuclear stress echo or a pharmacologic stress echo.
I'm doing 30 minutes on the treadmill right now.
Time doesn't mean anything. It's intensity.
Okay.
Because the load is only this, right? So I could have a piece of paper and I could put this car on it, right? And it may be able to hold for 30 minutes, but if I put this thing on it or it's not going to hold. So it's not just time. That's the mistake that many people make, is they go by exercise time and they assume that indicates exercise tolerance, and tolerance is equal, if not more, intensity based than it is time-based, because nobody says I can walk for 15 minutes at the same level, but on the 16th minute, I collapse. No, it's that when I walk up a hill, when I walk up a flight of stairs, when I run for the bus. You understand?
I do. Thank you very much.
You're welcome.
Appreciate it.
Somebody made a comment that said the 6-minute walk test is only good to get your O2, but if your rehab has built up your lungs, then your O2 doesn't always hit that magic number. And that's true. There's a requirement to get oxygen, right? Like you have to desaturate. If you don't desaturate, then you don't qualify for the test. That's why another reason why I don't love the 6-minute walk test. So for people who desaturate quickly and easily, then yeah, you get the info. But for somebody who might be a little more fit, or who it might take a lot more to get them, to desaturate, it would be a shame if they don't get their oxygen because the test is not vigorous enough for them and they're denied oxygen, but then they're hypoxic when they walk upstairs.
That happened to me. I had to run on my 6-minute walk test.
That's right. And that's why I say you shouldn't have to run. There should be a test that elicits that information in an organized way and a more comfortable way, right? Because let's say you have spinal stenosis. Can you run? No. Let's say you have a broken leg. Can you run? That doesn't mean you don't need oxygen. So, there's better ways of getting that info. Let me see other questions. Why isn't pulmonary rehab recommended ASAP other than insurance purposes? It should be. It should be. We're about to do our own online pulmonary rehab program. Why? I've been against it for a long time, but I see other people are doing it, and it kind of makes me mad. So it's like if someone's going to do it, we're going to do it, and we're going to set the standard for it. Because you know what? I wrote, where did I write this? I wrote it recently where I said I used to consider online rehab to be an oxymoron. But the simple fact of the matter is that 90% of people who need rehab don't have access to it for whatever reason. Either it's not there or their doctors don't refer it. So is it better than doing nothing? Absolutely. So we're hopefully in the next 4 weeks, we'll be rolling that out. But again, you have to be careful with that. You got to do the screening. You got to do these tests that I'm talking about. You got to have a good cardiologist. And for people with respiratory disease, I think it's worth their while to have an internist to have a cardiologist, at least for baseline measurements, at least to get the idea of, are they going to be safe to exercise?
What's the second and third most important piece of equipment to add other than a treadmill to my home exercise?
After that, it doesn't matter as much. I think the treadmill is the single best. I think you got to do something for your upper body. So if you could get a UBE, that would be great. Or, I mean, a new step is a great thing, but people usually don't turn it up fast enough. I mean, not fast enough, but they don't make the intensity high enough. So people love the new step. Of course they do. It's like a chaise lounge. Just sit down. And you're like, yeah, it's awesome. I get to talk to my friends. But I think that's a great machine.
Rowing machine?
Rowing machine is great if you can do it. It's vigorous. It's vigorous because it's a full body machine. Everybody thinks it's upper body only, but it's a vigorous machine. The mechanical aspect of the rowing machine that is a question mark is that when you come in, you're compressing your thorax and abdominal cavity. So that can make people more short of breath. But by doing that, it's going to make you, I would recommend using the rowing machine a few times before you purchase a rowing machine.
No, one of our patients who's having a problem with audio is trying to ask a question. The question's a simple one. I think I know the answer, but I'd like to hear yours. She wants a second opinion at University of California, San Francisco lung program, multidisciplinary team. She said, should I ask for one or wait?
Ask for one. What are you going to wait for?
Got it.
What are you going to wait for? What are you going to let all this stuff rattle around in your head? Even if they give you horrible news, at least you know the truth. You know what I mean? My number one principle in life is living with authenticity and truth, right? You may get bad news, but what are you waiting for? Right now, you're worried about it. Like, oh, I hope my doctor's doing the right thing. And a good doctor is not going to be insulted by you wanting to get a second opinion, okay? A lot of times people say, you know what, I'd like to get a second. It doesn't happen to be a lot. It happens to be maybe like once every 3 years. But if someone wants to go to NYU and see if they like that better, by all means, go for it. And if you like that better, more power to you. But a good physician or any clinician will welcome a second opinion because we should be putting the patient's needs first. And you know what? We sometimes miss things. There are things that can get missed. And if I miss something, I sure hope that somebody else catches it before my patient gets hurt. Why wait? If you have a question about something, why wait? I wonder if my wife is cheating on me. Should I wait a few weeks? I don't know. You know, I feel like if you're gonna get that info, get the info. You know what I mean? Get the info now. It'll put your mind at ease. And even if it comes back and you know what is a great thing when somebody goes for a second opinion, because everybody hopes to go there and be like, you know what? Your doctor forgot this. And then everything's going to be okay. Don't expect that, right? Although there are people who are diagnosed and then the diagnosis changes to something that's more treatable. But if you get a second opinion and they come back and they say, you know what, I agree with everything that your doctor's doing, that should be very reassuring to you because that means that you're maximally, you're being treated, you're medically maximized. So to me, if I have a question about something, if I'm wondering if someone's mad at me or something like that, believe it or not, that does happen once in a while. I'll ask them. I'll be like, can I ask you a question? Why let that rattle around your head where it's only going to do damage to you, right? It's only going to provide increased sympathetic stimulation. It's going to raise your heart rate. It's going to raise your blood pressure. It's going to raise your respiratory rate and make you more short of breath, right? Get the info. Info is power. Even if it's not what you like, even if it's not the info you were hoping to hear, it's still powerful.
I have a question. I'm not sure if you can hear.
I could, hear and see you. Sue, right?
Yes, thank you for taking my question.
Sure.
I don't have IPF. I have PF due to autoimmune.
Okay.
And I also have polymyositis.
Okay.
And I find that when I exercise at home on my treadmill, my legs get very, very weak. Now, I'm not sure if that's attributed to the polymyositis or, like you were saying, I may not have the correct cannula. I may need to be using the bag because I need to turn my oxygen up to 10.
So it's not due to your legs getting weak is not due to not having the right cannula, okay, or not having the right oxygen. Your legs getting weak are part and parcel part of polymyositis, okay? And with some of the autoimmune diseases, there's a very, very fine line between getting the right amount of exercise and overdoing it, okay? So, for example, rheumatoid arthritis, lupus, polymyositis. Polymyositis, one of the classic symptoms is pain and weakness, right? Now, let's talk about your oxygen for a second. So you say you need to use 10 liters of oxygen. How are you getting that 10 liters? From a cannula or a concentrator?
Cannula.
I'm sorry. I meant from a tank or a concentrator?
Concentrator.
You have a concentrator that goes up to 10 liters per minute?
Yes.
Okay. Continuous.
It's a wall unit, yes.
Okay.
A plug-in.
That with a cannula, right?
Yes.
Okay. And what's your saturation?
Well, it actually drops even at 10 now.
Right.
So,
because over 6, it's like this. I have a wine glass, and that wine glass holds 6 liters, right? Or 6 ounces. You're putting 10 ounces into it, 4 ounces winds up on the table, right? So
yes.
if you were to switch to a mask right off the bat, my guess would be you'd be able to come down in liter flow, which is not necessarily necessary because it's a concentrator, so you're not losing. But if you had a tank where you would be interested in conserving oxygen, then that would be a major factor. But yeah, you cannot do that with a cannula. It's not enough. So if you were to get a non-rebreather mask, and these things, you can get them for under $5 on the internet. I think you see an immediate major change. And there is a slight chance that you're getting some leg discomfort because of hypoxia. I don't think so. And the reason why I say I don't think so is because the body is smart and the brain is smart. The brain is, I could make some political jokes right now, but I'm not going to.
Okay.
There's people from all around the country here. I'm not going to make any political jokes, but from what I'm about to say, you'll be able to intuit what I'm talking about. The brain is smart. So when you're not getting enough oxygen, the brain is going to protect 2 people, the brain first and the heart, right? So yes. The idea is that when you're hypoxic, your body is going to suck in all the blood away from the extremities and, to the heart and to the brain. My feeling is that it could be, lactic acid buildup in your legs. It could be hypoxia. I don't think it is. I think that, I think the fact that you're desaturating even on 10 liters means that you're pushing yourself towards anaerobic metabolism, which is not very efficient. But first order of business, turn up your oxygen. Not turn it up. Get the non-rebreather mask. You'll probably, my estimate would be that you could come down to 6 liters, and you can email me and tell me if I'm right or not. I think you'd be able to come to 6 liters on a mask. You can't do less than 6 liters. But 6 liters, that would give you, a much higher concentration of oxygen. And by using the mask and the bag, you get that reservoir. So it's the difference between, you're doing something with tools or you're running a race with a baton. It's the difference between having that baton right there waiting for you or having to wait for that baton, right? Because
yes.
if you're only getting 6 liters, like at 10 liters, you're probably only getting really 6 of them.
Yes, I kind of wondered that, and then I wonder if I'm better off doing shorter amounts of exercise.
That was the next thing I was going to say. So with the autoimmune diseases, there is a fine line. So I would recommend how
twice
long are you doing now?
Well, I try to do 30 to 45 minutes, but but I always have to stop. I can't make like 6 minutes straight.
Are you doing interval training?
No. Okay,
so here's an idea for you. Start off your treadmill very, very, like what speed are you going at?
It's like 1.1 or 1.2.
And any incline?
No.
Okay. here's my recommendation. Cut it back to 0.8 if that's not too low for you. Or if you're trying to 1.0, do 1.0. Do that for 5 minutes. At 5 minutes, go from 1.0 to 1.1 for 5 minutes. Stop. Take a break. 5 minutes later, you start at 1.1 where you left off.
Okay.
After 5 minutes, you go to 1.2.
Okay, awesome.
Take a break. Okay? 5 minutes. After that, you start at 1.2, then go to 1.3. And once you can get to 1.4, then we're going to start talking about incline a little bit.
Okay.
That's the way to do it. And you little by little increase the intensity. And what you'll find is that over time, you could do more time and you can also increase the intensity.
Yes. And I have noticed that, I mean, I have been kind of doing that. I'll do what I can, then I'll step to the side and catch up and then start again. Okay. So then my next
point that I just said is that start lower, excuse me, start lower than you've been starting.
Okay. And then, so I think that because I have been doing things incorrectly, you know, this may have given misinformation to transplantation because it's recommended that I get a transplant. I feel like I should possibly give myself more time and try this method before I jump into a transplant.
Are you currently listed?
No. They said I need to lose about 7 pounds and get on the list.
So we're not there anyway. We're not there anyway.
Almost.
Okay.
But
so the idea is you do this program. Look, you don't want to rush to transplant. Nobody wants to transplant, okay? Transplant's a last resort. And the other problem with transplant, if it were curative, right, like a bypass,
right,
15 years out of a transplant, then when you actually get it is less important than that 5-year window, right? That most people would try. I mean, I have a lot of patients who've gone past 5 years, but when you get that transplant, that hourglass is ticking. So the idea is you want to hold off as long as you can without dying, of course.
Yes.
And then you get the transplant and you maximize the whole period of time. But you have to look at these things as big picture, right? Not as individual isolated incidents. You have to look at how does this play into my entire life? And what will this do? And what cascade of dominoes is this going to set off once I do that? But if you can lose more weight, okay, and you can get much fitter and move yourself further away from transplant, well, that's the goal, right? I mean, you look like a young woman, so.
Yes, and I have a 16-year-old and a 17-year-old, well, and 20 and 21, so I don't want the transplant right now.
You have a 21-year-old, a 20-year-old, a 17-year-old, and a 60-year-old?
Yes.
You were busy. Your house was busy when they were kids. But the idea is keep losing a little weight. Okay, treat the polymyositis, right? Because the other key to all these things is not to just say, well, I have polymyositis, or I have Sjogren's, or I have scleroderma. It's not to just say, okay, let those things go. The key is to address those issues as well.
I don't know how to treat the polymyositis.
The key is go to in the same way that we're talking about going to the best lung specialist, go to the best autoimmune specialist, wherever that may be, whatever it takes. Maybe there's
I have a rheumatologist, but I'm just being treated with Celcept and prednisone.
And that may be all you could be treated with. And that may be all you could be treated with. But then also there's other things like physical therapy, acupuncture, things like that. You have to look at all the potential ingredients that we can put into this sauce. And then depending upon how the sauce tastes, you don't add everything at once because then you don't know what's affecting the flavor, right?
I understand.
How this sauce tastes, then we say we might put in a little acupuncture. We might put in a little physical therapy. In addition to this, we might put in some hot packs or a TENS unit or this and that. But I think you might have been overdoing it. And if you cut back to a total of 30 minutes while following this stepwise progression that I said, I think you might see some success. So,
and would you do that daily?
I think you could do it 5 days a week. I think your body, especially again with the autoimmune, they are very prone to overuse, right? So you have to be careful. Don't hammer it so hard that you flare your polymyositis.
Okay. And I have one other question, which I'm not sure if you'll be able to answer or not, but I'm sorry?
This one I'm going to have to charge you for.
Okay. You can send me the bill. It'll be worth it.
Okay, go ahead.
I don't know if you have any experience in how to quickly involve family members that don't understand. For example, my children, they know I've been sick since 2002, but they still think that I'm in that same state, even though I've progressed. And I don't.
Getting worse.
Yes.
So yeah, I have a lot of experience with that. You know, it's very delicate, and you're dealing with emotions and feelings, and you know, no children want to believe that their parents are really sick. I think education is key. So I would recommend, you know, watching videos like this, or watching, you know, a great kind of intro sampler to ILD is the webinar that I did with Dr. Kainer. It's on our website. But educate them, and, you know, you have to, again, this is where authenticity comes in. And, you know, you have to say, I know that you don't want to hear this, but I need you to hear this, okay? By me constantly having to swim against, I'll give you a situation. I had somebody I recently worked with, or somebody, you know, everything that's not helping you is hurting you, right? And if you have to expend your energy trying to convince somebody else that
I do.
that is a waste of your energy. That's not a good use of your energy.
No.
So you have to educate them, and sometimes, you know, asking a health professional to have that conversation with you and with them is a plus, because, you know, it's like, I'll tell you a funny story. My mom, okay, I went to physical therapy school. I graduated when I was 21. I became the chief of cardiac and pulmonary rehab when I was 24 at NYU Medical Center. Opened my own practice at 28. At the age of 30, okay, by that time in my life, the most impressed that my mother ever was with me was one time when she had she was having her kitchen redone, and she always was raving about this builder, Kevin can do anything. Kevin can do this. But this kind of cabinet came that folds in and folds out. It didn't come with instructions, and he couldn't put it together, okay? So I said to myself, there's only 4 ways it could be. I know I could put this together. My mom's like, don't try it. If Kevin can't do it, it can't be done. They go to sleep, right? I look at it. There's only 4 ways it can be done. At like 2 a.m, I get it together, and I scream up the stairs. I'm like, say hello to my little friend. Both parents come down the stairs. My mom couldn't believe it. She was in shock. She was like, I can't believe Kevin couldn't. That was the most impressed she ever was with me, despite all my other things that I've done. My point in telling you this is that sometimes when our family tells us something, we totally discount it. We don't take it. We don't absorb it, right? You could ask your son or your daughter something. They'll ask you something, or you'll tell them something. Goes in one ear, out the other ear. But if Bill Vick tells them that, they're going to be, oh, you know what Bill told me? So I would say involve others if necessary. Ask them to come to a healthcare visit with you. Let the people know ahead of time what you hope to accomplish in that. And sometimes it takes therapy. Sometimes it takes, you know, seeing a social worker, seeing a psychologist, seeing a psychiatrist.
Yeah.
To get that message because
I have tried the palliative care at the hospital, and they didn't have anybody to talk to my kids. So I don't know where to turn.
That's unfortunate. That's sad to hear. But you'll find, so ask your doctor, or find a therapist who is experienced with chronic diseases, or, you know, you'll find them. Do an internet search.
Okay.
There are people all around, and, you know, with the way that people communicate today, I'm sure a lot of this stuff can be done remotely, even if they're not in your town.
Yeah, I would love to be able to find someone. I haven't. I've searched and can't find. That's one of my biggest struggles, is because I cannot get extra help around the house, then I don't find myself being able to devote as much time to doing my own therapy.
Agree. You need more support from your medical team.
Yes.
Other questions?
No,
Thank you so much.
I just got a couple of notes. We have people that have to leave, and it's noon, and you have been absolutely sensational. And I don't think there's anybody on this call that isn't just thankful. Thankful is not the right word.
Life-changing.
I think you open up visions and views for us that everything is possible if you know you want to make it possible. And great advice. This will be recorded. It'll be featured on the PF Warrior site. I'll send you a copy of the video, Noah, so you can put it on your site and share it in your audience.
Thank you.
And this has been just, I think, one of the best meetings I've attended on PF, maybe the very best one. The ability to ask questions and get answers and this interactive exchange, I don't know about everybody else, but I think is just fantastic.
Life-changing.
Thank you very much.
Thank you.
Everybody. Enjoy.
Thank you.
Thank you, Noah. Thanks all for attending, and I'll have a note out as soon as this is all processed and edited. Probably the first part of this next week, we'll get it out. I'll make sure you're all alerted.
This is great, Bill. Thanks.
It is.
Yes.
Thank you, Eileen.
All right.
Very life-changing. Thank you.
All right. Bye-bye, guys.
Bye-bye.